Assalamu alaikum. The clinical day, the scenario, Mrs. Sophia Anderson, she's 78 years. The role, you are the doctor, the on-call medical registrar. This lady has been admitted for severe community-acquired pneumonia. She has responded well to the IV intravenous antibiotics and has been converted to oral antibiotics therapy, amoxicillin and clarithromycin. Over the last 2 days, she has noticed a swollen right knee. It's increasingly painful and warm. Please sit with her and you might examine the patient and address her concerns. If you're ready, Dr. Ayn, we can start.
Yes.
Okay, here you go.
Hello, my name is Dr. Ahmed. I'm one of the doctors in the ward today. May I confirm that you are Miss Sophia Anderson, 78 years old?
Yes, doctor.
Nice to meet you, Miss Sophia. Miss Sophia, I'm
Thank
here
you.
to ask you some questions about your health condition, and I will need to examine you and answer all your concerns. Is that okay with you?
Yes, doctor, sure.
So can you please tell me how can I help you?
Yes, doctor. After being admitted here in the hospital, I was okay after taking the treatment for my chest infection. But yesterday I started to get swelling, which was mild, but now I think it increased more and more.
I'm sorry for that, Miss Sophia. Can you please tell me where is the swelling exactly?
In my knee joint, doctor.
Which knee?
Right knee.
Is it the first time to have this swelling?
Yes, doctor.
Okay, and is it associated with pain?
Yes, doctor. At the first, it is not painful when it is mild and small, but with progressing of the swelling, I feel, yes, it become painful.
Okay, and have you noticed the pain going anywhere else apart from the knee joint? Do you feel the pain going to the leg down?
No.
Okay, and on a score from 1 to 10, can you please rank this pain for me?
6, doctor.
I'm sorry for that, Ms. Sophia. We'll try our best to help you. And have you noticed anything increasing this pain? For example, when you move the knee?
No, doctor. All over the time.
All the time you have the pain?
Yes.
Okay. When you got the pain for the first time, was it sudden or gradual in onset?
Gradually, doctor.
And is it worsening till now?
Yes.
Okay. And you told me all the time the pain is there. It's not in ataxia?
No. It is increasing.
Okay. And is it more with movement?
Yes.
Okay. Have you noticed anything makes it better? For example, painkiller?
No, doctor. I didn't receive anything.
Okay. Is there any redness around the joint, the knee?
Yes, doctor. There is some redness, and I feel
Okay.
it hot also.
And have you had any trauma or fall?
Yes, doctor. While I am going the day before yesterday to the toilet, I hit my knee joint in the table.
Okay.
But
And
at that time, I didn't feel anything, and the next day, I started to feel that it started to be swelling. Yeah.
okay. Is there any other pain anywhere else in the body?
Yes, doctor. Sometimes back pain.
Back pain since when?
Since a long time, doctor, go on and off.
Okay. And where exactly in the back? Which area?
Lower back.
Okay. Do you feel it going to your lower legs?
No.
Okay. And have you done any investigation for this lower back pain?
Yes, doctor. My GP do for me some images, and he told me this is some changes from my age.
Okay. And have you had any back trauma or back or fall in your back?
No, doctor, no.
Okay. And on a scale from 1 to 10, how would you rank this back pain?
2 or 3.
Okay. Have you noticed anything worsening this back pain?
No,
Okay. Do you have any stiffness in the morning? Back stiffness or stiffness in
no,
any way? Okay.
no, doctor.
Okay. And um, do you have any problem with controlling the water work or the stool?
No, no,
Okay. Do you have any weakness in any part of the body?
no,
Do you have any problem with feeling or pins and needles?
no,
Okay. And do you have any skin rash?
no.
Okay. Do you have, can you give me your past medical history?
Yes, doctor, I have high pressure and
Mhm.
also some problem in my heart.
Okay. What
Mm-hmm.
problem exactly? Do you know?
I I don't know actually my problem, doctor, but maybe something in my heart beats.
Oh, okay. Is it a fast heartbeat or irregular?
Yes, they told me it is irregular, doctor. Yes.
Okay. And apart from that, do you have any other problem? High blood sugar?
Yes, doctor. I have also some issue in my thyroid gland.
Mm-hmm.
Mm, Yes,
What is the problem? Is it like underactive or over, like working slower or
no,
too much?
no, doctor. It's hypo. It's lower.
Okay. Any other problems?
No, doctor.
Okay. Can you show me your medication list?
Yes, doctor. My medication list is warfarin,
Mm-hmm.
thyroxine, thiazide,
Mm-hmm.
atenolol, and paracetamol for my back pain.
Okay. And any recent change in the dose in
No, doctor.
any of these medications? No.
No, no.
Okay. Are you compliant with these medications?
Yes, doctor. And
O-
additional now, they give me the medication for my chest infection also.
Okay. Okay. Do you have any raised body temperature?
Um, at that time when I admitted to the hospital with my chest infection, yes, they gave
Mhm.
me the antibiotic. I think clarithromycin. I think.
Okay. I mean
And
now
after
after,
this,
yes.
I don't know. Now my chest infection is improving too much.
Okay. Um, do you have any lumps or bumps anywhere in the body?
No,
Okay. Do you have any weight changes?
no,
Any weather preferences?
no,
Any bleeding under the skin or bruising?
no,
Okay. Any cough or coughing of blood?
no,
Any bleeding from anywhere in the body?
no,
Okay. Do you have any headache?
no,
Any dizziness or dizziness on standing?
no,
Any problems with vision? With your eyes or
no,
vision?
no,
Okay.
no,
Okay. Any chest pain?
no,
Any shortness of breath?
no,
Any cough or coughing of blood? I think I asked you.
no, 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 doctor. Cough at
Okay.
when I admitted to the hospital with a chest infection, but now improved.
Okay. Any awareness of heartbeat?
No, doctor. I feel I'm controlled now on the medication that I'm taking.
Okay. And do you have any tummy pain or tummy bloating?
No,
Any change in bowel habits?
no,
Any change in your water work?
no,
Okay. Do you have family history of any joint problem?
no.
Any family history of note?
I don't know, doctor.
Okay. And have you had any surgeries or procedures in the past?
No.
Okay. And can I ask you some personal questions?
Yes.
Do you smoke?
Stop the doctor.
When did you stop? May I ask you?
5 years back.
Okay. And do you take alcohol?
No, no, no.
Okay. Do you have a partner?
No,
Okay. Do you drive?
no, doctor. I can't drive because of my back pain and my age.
Okay. Miss Sophia, can I examine you?
Sure, doctor.
Okay. I'd like to know the vital signs of the patient. Any
All
raised
normal.
temperature? Normal. Okay. Now I'll start examination with the affected joint, the right knee.
Okay.
Inspection for any rash, any bruising, any obvious swelling.
No, only swelling. Yes.
Okay. And then, do you have any pain, Miss Sophia? I would like to feel your knee joint. Is it okay?
No.
I'll be gentle.
Okay, okay, doctor. No problem.
Okay. So I will feel the swelling, and
Okay.
I'll feel the temperature over the joint. I'll compare both sides, both knee.
Okay.
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 And then I would like to do some movement. Miss Sophia, can you move the joint for me, your leg for me?
Limited due to the pain.
Okay. Any bruising anywhere else in the body, in the legs? I will scan the
No.
legs. Okay.
No.
What about the left joint? Is it normal?
Normal.
Okay. Then I will do peripheral examination for the hands. Any abnormality, any
Okay.
joint involvement?
No.
Okay. I'll check the pulse. Is it good
It's
volume? Yeah.
irregular, but within normal heart. يعني normal heart rate is about
Okay.
80. Mm.
Okay. I'll check for conjunctival pallor.
No.
Okay. I think that's it. So Miss Sophia, I want to ask you one more question. Do you know, do you do regular follow-up for your warfarin, the special blood test?
Yes, usually, doctor, I do. And last month it was 2.5.
Last month, 2.5. Okay. Um, okay, Miss Sophia. What are your concerns, Miss Sophia?
Yes, doctor, what I have?
I highly appreciate your concern, Miss Sophia. Miss Sophia, I believe that because of the bug medication, the antibiotic that you took in hospital, your blood is becoming more thinner than usual because of the warfarin that you are taking. And most likely due to the trauma that you had to your knee, this also led to accumulation of blood in your knee joint. Are you following me?
Yes, yes, doctor.
Yes. So for now, we need to do some blood test and we need to check how thin is your blood by doing this special test for the warfarin. And we need to do X-ray scan of your knee joint. Is it okay with you?
Okay.
Okay.
It's okay, doctor, but can I do it as an outpatient because I'm in hurry to go home, and my lung doctor said to me also that I will be discharged.
I believe, Miss Sophia, it's better to be done in hospital because we don't know how much is your blood thin now. It might be very thin that any minor fall or trauma can cause serious injuries and serious bleeding. Uh, so better to do it in hospital while you are still admitted.
Two
Is it
minutes
okay with
left.
you?
Okay, doctor. Okay.
Okay, we need to give you some, if confirmed, after we might also need to do ultrasound. That is the scan of your joint. If confirmed, that is most likely a bleeding. We might need to give you a medication to reverse the effect of this. Most likely, we'll give you a medication to reverse the effect of this warfarin. Is it okay with you?
Okay, doctor, no problem.
Okay, Ms. Sophia. Any more concerns for me?
No, doctor.
Thank you for talking to me.
Thank you.
Okay, are you satisfied, Dr. Ryan, with the history and the examination? You want to go to the examiner?
Yes, I think fine.
Okay. Yeah, Dr. Phoebe, you can start now. Examiner question.
Yes. Can you give me the diagnosis and differential diagnosis for your case?
I think my top differentiation is likely like hematoma due to supratherapeutic INR, most likely because of the recent start antibiotic, erythromycin. Another diagnosis could be just due to the trauma. Also, another differential could be thiazide-induced gouty attack, but that will be very less likely because the patient had no previous attacks.
Okay.
I think these are my top differentials.
Okay. So, how to investigate this patient?
So apart from the basic investigations, full blood count with differential, renal function panel, liver function panel, coagulation panel with INR, and we will do ultrasound of the knee joint and X-ray.
Mm-hmm. Do you need to do anything else?
Anything else? Nothing in my mind, صراحة.
Okay, so what you will give this patient, or how to treat this patient?
So non-pharmacological disease education and counseling, and for now we need to stop the warfarin and maybe give the patient an alternative for the atrial fibrillation. For example, low molecular weight heparin, as it will be easily reversed and easily stopped and short half-life. We have to give the patient supportive management analgesia. We will give vitamin K. And we can involve ortho as well, multidisciplinary team approach with ortho and physiotherapy when the patient is pain-free. I think we might need to change the antibiotic as well, or adjust the warfarin dose later on.
If you will do aspiration for the joint, so you will do aspiration now, or you will do after stop the warfarin?
I think after stopping the warfarin and make sure that the INR is not supratherapeutic.
Okay.
Because it will cause more bleeding into the joint if we did it now.
Yes. Okay. Okay. Finished.
Okay, I will continue some questions in my mind.
Okay.
You mentioned vitamin K, Dr. Ryan. You will give vitamin K?
I think so. I will give vitamin K. Why?
Okay. Yeah. You will give, first of all, you will give by yourself?
لا, I will involve.
Okay.
I will involve the hematologist.
Okay.
Hematologist,
First,
orthopedic.
INR level.
Yes, that's why.
Yes.
This is the next questions. Yeah. So you will start immediately the vitamin K, or you will do more investigation if you want to do it by yourself. What's your decision?
لا, I will do the INR first.
Okay.
No,
and
INR, X-ray, and ultrasound.
Okay, let's talk about the INR itself. How much and when you will give vitamin K and how?
Okay. If the what I remember that if the INR is above 5 أعتقد 5 to 8.
Yes, above 8 or from 5 to 8 and less than.
Yes.
Okay.
So if there is bleeding, with bleeding, we will give vitamin K.
Perfect.
If there
major
is no bleeding.
No, if there is major bleeding like ICH, what you will give? And above than 8?
Above than 8, we will give vitamin K IV, and we will give لحظة, let me remember.
Yes, remember the name.
BCC.
Yes, perfect, yes. Prothrombin complex, right?
Prothrombin complex.
If more than 5 with minor bleeding, and if more than 5 without bleeding.
If more than 5 with minor bleeding, we can stop vitamin K بس.
With minor bleeding, no. If no bleeding, yes, you will stop it. Hold it, not stop, hold.
Minor bleeding, I think we give oral vitamin K.
If yes, with vitamin, yes.
Minor bleeding.
Yes, if with the minor bleeding, you will give vitamin K orally. But if more than 5 with no bleeding, now you will hold.
We stop it. أيوه.
Hold it.
Hold.
Yes.
أيوه, hold.
Yeah.
Few
So
doses.
the best way,
Cold. Huh?
yes, the best answer to all this drama and dilemma, what you will do?
Involve hematology?
Yeah, better, yes, because if you said I will give vitamin K, it will be unsafe. Your patient is AF. You have to judge on the INR, not by your
Oh,
decision due to minor bleeding. I guess this patient has minor bleeding, not major. The time is up. So give me one more differential if this patient having joint pain
pseudo gout
or
بس
joint. No,
لحظة
chronic.
قد
Yes. Yeah, once you said lahza, you will get it.
لحظة let me think.
In the same area of the bleeding, the same area as a differential. Very important differential in bases. Happen with rheumatoid.
Mm,
Rheumatoid arthritis. Rheumatoid arthritis.
rheumatoid?
Something happen as acute onset and it's severely painful and need to be rolled out.
Need to be rolled.
Yes, someone wrote it. Yes, definitely.
What is
Dr.
it?
Tabassum. Dr. Tabassum, yes, and Dr. Sam. Yes,
Mm,
Becker cyst, rupture Becker cyst. Yes, you're right.
okay.
This is the one, yes. DVT, I guess it will not be more painful, Dr. Ahmed Mahan. But still one of the differential. You have to rule out any immobilization. You have to rule out any, because this is emergency. Okay.
And we need to rule
Mm.
out also septic arthritis.
Mm.
Septic arthritis in this patient, I don't know what the risk to say it's septic arthritis. If unless she has history of osteoarthritis, diseased joint, yes, you're right. Fever and night sweats, some alarming and B symptoms. I agree, yes. Okay, let's hear the comments from Dr. Phoebe. Anyway, you did well, Dr. Ryan. Dr. Phoebe, you can
Thank you.
comment.
Yes, I wanted to comment بس on the examination. Because you for the knee examination you must to do full knee examination and to examine the calf muscle for possibility of DVT and the also the popliteal fossa for ruptured Becker cyst as you told Dr. Bessa.
Okay.
Yes, I
And then
agree.
for
Go ahead,
and
continue.
then also yeah for investigation we must to do the full basic investigation with full inflammatory markers also
Mm.
Agree.
and uric acid and all these things. And also we must to tell the patient that we are in need for aspiration of the joint because we don't know the nature of the collection. So I think after يعني ان احنا نشوف ال INR level
Yes,
so we will do the aspiration to know if it is blood or to examine the fluid, send it for culture and for gram stain, crystals, everything.
agree. Yes, cell count. Yes, agree. Okay, and anything else related to the performance
And
skills?
also in history also
Yes,
you didn't ask about the control of hypertension. I think if I'm
Mm.
compliant to medication and
I think I asked
any
Eric, are you compliant to medication? But I did not ask, like, how is your blood pressure?
mm,
But I asked, are you compliant to?
mhm.
But maybe I need to ask in specific, you mean?
Yes.
Okay.
Just it. I think nothing else.
okay,
And
thank you.
what are the differentials? Anything else in the differential? Well,
Uh, yes, the differential, first differential as written in this scenario is the hemoarthrosis, as you told, because of the interaction between warfarin and clarithromycin. And second is gout, osteoarthritis, and lastly septic arthritis. But against this, that the patient has no fever
okay.
or no general symptoms. Yes.
Yeah, perfect. Thank you, Dr. Phoebe. Very nice case.
Thank you.
I
Thank you so
think,
much. Good
yes.
case.
Yeah, I will comment firstly on Dr. Ryan. As usual, she is perfect. I preferred once you have patient 70 plus, I will give you an advice if more than 30 even. Better to
Mm.
ask about past medical history of note, any medical condition you are diagnosed with.
You
78
mean before I
before
start with the analysis?
system review. No, no, no.
Because
After analysis,
sometimes
you have to finish.
ah
No, no, no. After analysis, of course, you will know the
okay.
analysis. You have to know the analysis and to do it because you have to know what's the nature of the pain. Is it mechanical
Okay.
or inflammatory?
Mm.
Definitely, this is a mechanical pain. And the good thing you ask about the pain, which is the precipitating factor. Really great to ask this question. And you correlate already to the pain, to the bleeding due to the trauma. But for the other interactions, the drama, the patient has a lot of medication, a lot of medical condition. And
Mm.
if you don't ask this question earlier, some doctors, I mean, they might ask at the end. He will be in trouble. In trouble. Why?
صح.
Yes. Why? What happened there? Is there interaction? If you are stuck to the time, you'll be mentally blocked. You have to ask this question early to know what's ongoing. A lot of medication in this patient. If you are stressed and panic, you might mistakenly relate it to link the cause to the medication. But because you are
Mm.
focusing, you got to the erythromycin or clarithromycin related to the interaction with the warfarin. And also you have to ask about diet. Is there any diet change? Any new diet you took in the hospital or before? Because always warfarin has a lot of interaction. This is general advice. For any patient having on warfarin, we should analyze the warfarin itself interaction with other medication, especially if you have a big list of medication, such patient, and the diet itself. Sometimes they will try herbal remedies, and the herbals, of course, herbals have also interaction with the warfarin. I mean the green vegetables and some of the vegetable, right? So try to ask this question. Back to the past medical history. If you don't ask this early question, you might be in trouble, believe me. Before going to the system review, finish the past medical history and surgery and allergy in the same time. Okay?
Mm.
This is my comment on your performance. Apart from that, I think you ask for the stiffness to roll out rheumatoid arthritis, right? You ask for the stiffness,
Yes, and
which
ankylosing
is,
spondylitis because she said the back pain. So I thought maybe long time back pain.
yeah, perfect. Okay, perfect. The judgment during the questions, you didn't go deep with the details of investigation. I don't know why. Yes, as Dr. Phoebe said, you have to think about everything inflammatory markers. Still, it's one of the hemoarthrosis,
Mm.
but also you can roll out and show the examiner that I put in my mind
Sept.
serious differential, yes, septic one, although no risk factor. I
Okay.
guess in this patient, it's difficult to ask about dysuria or not dysuria, I mean for the sexual transmitted disease, but at least ask if there is dysuria, discharge, UTI. It might be related as septic, to roll out septic.
Mm.
Okay.
And
Mm.
also a knee examination. You didn't tell the examination patellar tab to see if this is effusion or not effusion.
Mm.
Yes.
Okay.
Look, feel, move. Look, feel, move. Always remember these steps. Look, any swelling, redness, rashes, discharge, anything can you can notice deformity. Feel, you will feel the crepitus, you will feel the warmness, you will feel the effusion, and finally move. Always ask to passive movement and can I move you? If you feel pain, stop me. Don't say or don't assume the patient will have pain. Really, they will comment on that. I had a comment because of this charcoal joint, and I said because of the pain, I didn't try to mobilize because he mostly have a pain. He has a
Mm.
pain, and he wrote in my comment he didn't ask for movement, although I
Mm.
asked, I offered, but do it.
Mm.
Welfare, you can say one sentence. If you feel pain, stop me or let me know. Okay.
Okay.
If even if he said ah or ouch or he feel pain, at least you give him a warning that you might do this and he might have pain. But to leave it because of pretending that he might have a pain and I didn't want to do, they will comment on that. So look, feel, move. Passive movement, ask him to move by himself, and you move by yourself. Up, it's two direction only, up and down. You cannot move more than this in the knee joint. I mean, because the axis is the horizontal, right?
Mm.
Yeah, I think this is the case well
Any
done,
need to
Dr. Phil.
examine anything
Dr.
else? ولا any like do
I
I need to
I
examine
I,
anything
I
else
guess
apart from the knee?
I think
لا
I
in
guess
our
this patient.
I think no, it's general and usually to after taking the vitals, the most important to start the examination regarding or according to the patient
Complaint.
complaint. يعني a patient has
According
now
the case.
yes according to the complaint of the patient. The complaint
Yes.
is no is knee, so the first thing to be examined after vitals is knee.
Yes, sure. Yes, sure.
يعني do
Yes,
I
I
have
get
to
Then
it.
if you
examine
have
the back
time,
here in this
you can
also?
examine the chest because also the patient just recently had chest infection. I think so, yeah.
Mm.
If
And
you
do I
have
have to
time, but
examine the back as well or no need?
and the
Because
back
it's
as
a long
well. But
stand.
yes, but if you don't even do this, it's okay. But the most important to examine the knee joint and the leg in details, like to do
Yes,
Okay.
everything.
I agree.
Okay.
If there is swelling, Dr. Ryan, you can offer a tape for circumference, okay?
Okay.
To roll out there is symmetry, and you might tell him like I am thinking about DVT because, yeah, the limitation of movement in such age, it might lead to DVT, although it was hemoarthrosis. Okay, don't forget by the way, don't forget the hemoarthrosis in young as hemophilia A or B. It comes also in the exam, but this is related to the warfarin. And the good thing also, you ask about any bleeding from anywhere, any bruises, any easy bruising, or any bleeding, right? You ask all these questions.
Mm.
Okay. Sorry, someone was talking and we interrupted him. Dr. Abdulminim or who? Doctor?
Walaikum.
Alaikum salam, Dr. Azhar. Yes. How are you?
Salam.
Alhamdulillah.
Go ahead, Dr.
What was
Azhar.
the INR in this case? 2.5?
Suppose
No. What
supposed
the
to be, yeah. She said
what the
2.5, yes.
if the 2.5 it's normal, then why we'll stop this warfarin?
This was 1 month back, she said, but now she's in hospital and she's taking
The last
clarithromycin.
clinic, yeah, the last clinic,
Yes,
yeah, last
yes.
clinic. It was last clinic follow-up, Dr. Azhar. So you don't know
So we
how
don't
the
know.
current.
Yes, we
Yeah.
don't know how much more. Yeah.
So in the examination, I'm thinking that this patient is having atrial fibrillation and on a warfarin. Cardiac examination should also be done, in my
Exactly.
opinion.
Yes,
Yes,
sure.
sure.
The
And if we have
pulse.
time, then a general look on the thyroid because she also give history of past history of hypothyroidism. If time.
If you have time, or if you don't have time, say it. I would like to
Mention
do
it.
it.
Okay.
Yes,
Yes,
exactly.
yes, yes.
Mhm.
One of the tests you have to do also with
Can I ask a
clarithromycin.
question, please?
Yes, you can ask. Yes,
Which
who's
test?
asking, please?
Which
Good
test?
morning, good evening, everybody.
So sorry, the sound
What
is
was the
not
cause
clear.
of the back pain in the patient?
Sorry?
Sorry.
Okay, 1 minute. What was the cause of the back pain?
It's
The
still the
cause of the
sound
back pain.
not clear, Dr. Iman. I guess you are Dr. Iman. The sound is not clear. If you
What
can.
was the cause of the back pain?
Yes, okay. This is now clear. Back pain, Dr. Phoebe. Why the cause? What the cause of back pain in this
Just
patient?
only
Osteoarthritis.
itching, osteoarthritis. Yes, and I told already that the GB told me that this is degenerative changes from age.
Yes, at least she will have back pain. She's 78.
Yes.
Okay.
Okay. So it's common for osteoarthritis to happen in the back. It's more common in the knee joint.
No, the complaint was for knee joint.
Okay.
Accidental back pain during the system review.
Yes.
Okay.
It is not related.
So
can
the,
affect
the,
any
the back
joint.
pain should not be assessed in the examination?
Supposed to, but if you have time, we have a lot of finding in such age, starting by AF, as Dr. Azhar said, and pulse examination, thyroid, as she has hypothyroidism. The most important thing to cover here is the knee joint itself and compare to the other knee. If you have time, go up and examine any complaint she had, like back pain, the thyroid, the heart, if you have time. And if you don't have time, again, offer it. I would like to do, if I have time, I would like to do one, two, three. Okay?
Okay, thank you. Okay, thank you.
Most welcome, Dr. Most welcome, Dr. Iman. My question was, what test or what bedside test you want to do in this patient after taking clarithromycin?
bedside test.
Dr. Ryan.
Achilles tendon.
What?
Achilles tendon.
What
ما
you say? No, no, no.
I think ECG.
Something important. Yes, exactly. For what?
ECG صح.
Who said?
Me.
Who said ECG?
long
Me.
QT.
Yeah, exactly. Yes. Macrolide can lead to, especially with this, yeah, with ischemic heart disease, it might lead to long QT. Also, one of the safety and welfare points. Okay.
And just a question. So in this case, should I examine the normal knee first and then examine the abnormal?
No, no, the abnormal.
Okay.
Abnormal and compare it to the normal one.
And I have to do all the steps again in the normal?
No, 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 no. What you
just
are
compare.
what you are comparing the temperature and the effusion.
And the effusion. Okay.
Yes.
Why the knee joint was warm? It was written in the scenario.
The blood, the hemorrhagitis will cause worm.
Yeah.
Clear, Dr. Azhar?
Okay.
Good case. Thank you.
Yeah, very nice case. Thank you, Dr. Phoebe. You can post. Yeah, thank you.
Oh,
Post the case, Dr. Ryan, and I will read the
okay,
comment.
sure.
Can I ask which medicine patient was taking? She was taking a lot of medicine. She was taking for the blood sugar, for the diabetes, I think metformin, yes, and for the blood pressure, I guess she was taking
Iodide,
thiazide. Yeah, thiazide.
Thyroxine, warfarin, atenolol, paracetamol, then this for chest infection, clarithromycin, amoxicillin.
Yeah. Thank you, Dr. Azar, for memorizing this. You'll be assigned for the medication list for every scenario. Yeah, it's important, really. Believe me, it's important to start with the past medical history in such age. More than 50, you can make it a rule. But sometimes also with young patient, you might have type 1 diabetes and it will be also related. I give advice again and again, don't leave it to the end after systemic review. You'll be in trouble. System review will not find anything.
So
Or
how
But
do you
if,
one mentor
remember the
told,
medicines?
sorry?
one mentor told that after taking the presenting complete history, within 1 or 2 minutes,
Yeah,
immediately you will go to the past history.
yeah,
Immediately go.
exactly.
Then you will come
Yes,
back to the
yes, I agree.
analysis.
Agree 100%. Yes, Dr. Sam, what you said?
How do you remember all the medication when the patient can we write in the paper or not?
Yes, you can write in the paper and you can make abbreviation. Don't write the whole letters. Like paracetamol, you can write BCTM. The way you can remember the drug name,
Yeah.
put it, because you don't have time to write the whole medication and to
Yeah.
wait. Yeah,
But what I observe in the cases, I mean, like the way they do, always they give in the past history. I feel like
the medication list.
no, like a clinical consultation. Normally they give the past history most important.
In the
Prefer.
in the paper, you mean before going inside?
Yeah. Or no, anything
Yeah, yeah,
drugs.
yeah. They can write for you with the past
Yeah.
medical history of diabetes.
Yeah.
But sometimes with the stress, when you go in, you
Yeah.
forget, yeah, to ask about how is the control, how is the comorbidity, how is the.
Yeah. True.
So you will go through the system review. You will waste time without reaching any positive finding.
Yeah.
So the best way is to ask it immediately? Is it related to it? Any medication, any change, any added, any relation to the surgery, any procedure? You might have something with which can guide you to the case. Okay.
I feel like in PACES, like what we are practicing, and they always relate it with past medical history most of the time. I feel
Yeah.
like they just make us confused, like,
Sometimes distracting,
Yeah.
but yeah, most of the time, absolutely right. It will be related.
Yeah, thank you so much. It
Most
was
welcome. Most welcome, Dr. Zah. Okay, you post the scenario, Dr. Ryan. Mrs. Sarah Johnson, 35 years old, with vision loss. Thiazide, then pseudogout. Yes, we mention it. Why not? It can be both hemoarthrosis as well. Yes, agree. Dr. Phoebe, I'll give
Yes,
you 2 minutes.
I prepared already. We can start, no problem.
Well, okay. Yes, I reset the timers. Here you go.
Okay. Hello, I am Dr. Phoebe, the doctor in the medical unit for today. May I confirm that I'm speaking to Mrs. Sarah,
Yes, doctor.
35 years old? Yes.
Yes, doctor.
Mrs. Sarah, I have been asked to sit with you to take history, examine you, and finally I will answer all your concerns and take my notes, which will be confidential. So is this all right with you?
Yes, doctor.
Okay. So it come to my knowledge, Mrs. Sarah, that you are complaining of vision loss. Can you tell me more about this?
Yes, doctor. Honestly, over the past week, I noted my vision is deteriorating. It's getting less and less. Initially, it was blurry, and then today, suddenly, I cannot see at all. That's why I came today.
I'm so sorry, Mrs. Sarah, for what happened to you, but be sure that we are here to support you. So can you tell me any previous attacks before for loss of vision like this?
Yes, doctor, you are right. 1 year back, I had a
Okay.
similar episode, but it was a very short time. I did not need to seek any medical attention.
Okay. And it lasts for how many days? This one will come 1 year back?
Sorry, the previous one?
Yes, the previous
One
attack, I
day,
mean.
1 day only, 1 day only. But
1 day
this one,
only.
1 week now. Yes.
1 week. And gradually over the week, right?
Yes, doctor.
I'm so sorry for this. Can you tell me if you cover one eye, you can see by the other eye or no?
No, I am not seeing anything at all.
By the two eyes.
Yes.
I'm so sorry for this. Mrs. Sarah, do you have any headache associated with this loss of vision?
No.
Okay. And this loss of vision is total, even for light.
No, I think light I can like appreciate there is some light, but I cannot see stuff clearly.
Mhm. Okay. And there is any weakness in your limbs?
I think my legs are getting heavier over the time, over this week as well.
Okay. And any abnormal sensation or numbness in your legs or hands?
I think my legs as well, doctor. The feeling is not like before.
Okay. And what about your gait?
It's normal. Only because of the weakness, I had to use the cane today just to support.
Okay. And if there is any jerky movement in your limbs,
No,
any difficulty in breathing, any difficulty in swallowing?
no difficulty in breathing, doctor. But over the past week, I noticed that I am having hiccups, continuous hiccups. I don't know, they're not stopping.
It started with this loss of vision also gradually like this?
No, maybe around 5 days ago, after the loss of vision.
Anything make it worse or make it better?
No, I didn't notice anything.
Okay, and I'm sorry to return back to the weakness of your legs. Is it started gradually or suddenly?
Suddenly, doctor, on that day, but
Okay.
I feel it's worsening. But it's not very weak, but worsening.
Like a floppy or rigid weakness?
I think rigid.
In both legs, right?
Yes.
Okay. Do you have any problem in controlling your bowel or your water work?
Yes, doctor. My water work is I cannot control it like before. Also
I'm
over
so
this
sorry for
week.
that. Okay. So there is any history of trauma to your head, neck, or back?
Never.
Any fever or
No.
high temperature, I mean? Any tiredness?
No.
Okay. Any being sick or feeling sick?
No.
Any night sweats?
No.
Any weather changes?
No.
Any skin rash or skin changes?
No, doctor.
Any joint pain or back pain?
No.
Any loss of weight or gain weight? Any weight changes or appetite changes?
No.
Okay. Any changes in your bowel habits like loose motion, hard motion, any blood, dark stool, anything?
No.
Okay. You told me that you are not controlling your water work. So there is any frothy urine or any burning urine
No.
or change in amount? Okay. So also, I want to ask you about any past medical history that I should be aware about it, like raising blood sugar,
No, doctor. I am previously healthy.
no increased blood pressure, no cancer history, no nothing,
No,
huh?
doctor. No. No.
Okay. Okay. Any history of blood clots before
No.
in you or in your family?
No.
Okay. Any medication list you have?
No, doctor.
Okay. So what about your period?
It's regular.
And are you pregnant or are you planning to be pregnant?
No.
You take any pills?
No.
Okay. Are you smoking?
Yes, doctor. Just occasionally.
I advise you to stop smoking, and if you don't mind, we can refer you to the smoking cessation clinic. So, do you drink alcohol?
No.
Okay. So, also, do you drive?
Yes, doctor. I drive.
But I'm so sorry to tell you, you should stop driving right now because of this eye problem that you have until we reaching diagnosis and give you the proper treatment and assess you again after this. Is it all right?
Yes, doctor. Thank you. Okay,
Okay.
sure.
What you are doing for your life?
I am a teacher.
Is this impacting your work?
Yes, for the past week I couldn't go back. Couldn't go to work.
Okay, we will give you sick notes and also we will include the occupational workers to help you regarding this issue. Do you have any social problem or you want any social or financial support?
No, doctor. I am good.
Okay. Do you have any mood changes these days?
No, I am just worried
Okay.
about what's happening to me.
Yes. Mrs. Sarah, can I examine you?
Yes, doctor.
Vitals?
Vitals normal.
Okay. And I want to examine the eye for the visual acuity. If she has any, she can see the hand
Reduce.
movement or
Yes,
only
reduced
light
visual
perception.
acuity.
Okay,
Reduced visual acuity in both eyes.
both eyes. Okay, and there is any. Can I offer also fundus examination?
Yes, normal.
And the shape of the eye, any dropping in the eyelids?
No.
Okay. Also, I want to examine the lower limb for the power,
Okay. Power is 4 in both legs.
tone,
Hypertonia.
reflexes,
Hyperreflexia.
sensation, superficial and deep,
Sensation is lost to fine touch and pinprick.
To
Where
fine touch and
and
pinprick.
pinprick, yes. Up to the level of the umbilicus.
Okay. And as coordination, like
Could-
heel to shin.
Could not be done properly because of the weakness,
Okay.
but intact, let's say.
Okay. And I want to make her to do the gait for me.
Okay, normal,
any
but it's difficult because of her weakness, but
Okay.
like no ataxic gait, nothing.
Okay. And in the upper limb, I wanted to do also dysdiadokinesia and finger to finger test.
Normal.
Okay. And also I wanted to examine the chest.
Okay.
Any
What do you want?
abnormality in the heart sounds or murmur.
No.
I want also to examine the back of the chest for any breathing abnormality.
No, nothing. Normal.
Okay. And also I think I have time to do also upper limb examination for one of the power, one of the tone, one of the reflexes.
All normal in the upper lips.
Okay. And okay. So what's your concern, Mrs. Sarah?
Doctor, what's wrong with me? Why is my vision like that? And why I cannot stop from this hiccup? Can you help me?
Yes. Before answering the question, also I want to ask you some question regarding to this hiccup. Do you have any heartburn or acid brush?
No, doctor.
Do you have any throwing up?
Throwing up on and off, but over this week, but not much.
Over
Like the
over
hiccups.
this week?
Yes.
Ah.
I had
Okay.
a couple of times throwing up.
Okay. Also, I want to return back to examination if there is any jaundice or anemia in the eyelid. I mean.
No, negative.
Okay. So, Mrs. Tara, regarding to your concern, mostly you have a condition named multiple sclerosis, and this condition is a medical condition come in attacks, and it is due to defense in your disturbance in your defense system that instead of attacking bugs, it attacks your nervous system. I mean the nerve cables and some areas in the main nerve cable and in the brain. That's why these symptoms that you have. And so our management plan now is to run on some investigation in the form of blood test and also image to your brain and to the main nerve cable in your back. And also we can do some aspiration or some withdrawal of fluid around the nerve cable in your back also to confirm our diagnosis. And also we will involve the multiple specialty doctor like nerve doctor and also the specialized nurse, social worker and occupational worker to give you the proper management in the best interest of your case. And also after this, after confirming our diagnosis, we will give you the medication suitable for your condition. And after relieving the attack that you have, because as I told you, this disease coming in attacks, so we will assist you if you are in need to be on medication to prevent the recurrence of these attacks.
2 minutes left.
Is this all right with you?
Yes, doctor. Thank you.
No problem. Welcome. Any other concern, Mrs. Sarah?
I just want to know what's the reason for the hiccups.
I'm not sure, Mrs. Sarah, what is the reason for this, but maybe due to some affection also of the nerve supplying a part of our abdomen, which is called diaphragm. But we will refer to the nerve doctor, and he will assess you more and to give you the proper treatment for this.
Okay, doctor, thank you so much.
Thank you.
Okay,
Any more concerns?
No, thank you, doctor.
Okay.
okay, perfect, Dr. Phoebe. I guess you're done with the history and examination, so we can go to the examiner questions.
Yes.
Yes, go ahead.
Okay. Can you please summarize your case and the positive findings?
Yes, this lady, Mrs. Sarah, 35 years old, present with sudden loss, gradual loss of vision over the last 1 week, and this is associated with also weakness and impaired sensation with sensory level in her lower limbs with hiccups, and also there was a previous attack of loss of vision 1 year back. So, in view of all this from the history, my top differential diagnosis will be multiple sclerosis.
Okay, any other differential?
Yes, maybe something in the stroke. I can tell stroke maybe my second differential diagnosis, but against this that this is bilateral, and also it may be my bilateral weakness. I mean, but maybe in the occipital fossa stroke.
Okay, anything else?
Mm, uh, mm, no, right now, no.
No worries. Okay. Investigation?
Yes, investigation for this patient, apart from the basic investigation, including the full blood count, liver function, and kidney function test before starting any treatment. I will do for her also MRI brain and spinal cord. We can do also lumbar puncture for seeing the oligoclonal bands for MS, and for the visual evoked potential also we can do it, and for the limb weakness we can do some nerve conduction study and EMG. Just it. This is in my mind.
And what's your management plan?
For the acute attack that she has now, we can give methylprednisolone IV, and first of all, non-pharmacological treatment in the form of including multi-disciplinary team, including the neurologist and the specialized nurse, and also will include the physiotherapist, social therapist, and also we will give her patient education and patient counseling, and also bladder care because she has incontinence, and also food care because she has sensory affection or sensory sensation problem in her feet, and also pharmacological. Now during the attack we can give her methylprednisolone IV injection during the attack, and after the attack assessment of the patient because she may be in need for preventive treatment because I think she has 2 attacks in 1 year, so she may be to be in natalizumab or fingolimide.
Okay. Okay, I'll ask you some more questions. We still have time, Dr. Bassem, صح?
Yes, still.
Okay, can you tell me what are the poor prognostic factors in MS?
Poor prognostic factor, I think, if old age and if male more prognostic factor than females.
Yes.
Yes, and also if the course is not in attacks like progressive course.
Frequent relapses. Yes. Okay.
Yes.
Can you name disease modifying agents for MS? 3
Again,
agents. Can you name the disease modifying agents used for treatment of MS?
uh, fingolimod I think and
Fingolimod. أيوه. Yes.
yes fingolimod أيوة إيه هو ده
أيوه.
and natalizumab.
Natalizumab.
Antibody and what else?
Ocrelizumab. Another one.
Yeah, yeah,
Yes. Others are beta interferon and glatiramer acetate. Okay.
yes.
I think.
And I think
Thank.
also this patient, I forget to tell her that if you are planning for pregnancy, you must to inform your woman doctor and
Yes.
yes.
Yeah. Yes. Thank you, Dr. Fabi. Well done, mashallah.
Thank you.
Okay. I'll ask you one more question just to tell you the diagnosis. If this patient you did the MRI and it was negative, any other differential, or what do you think is the diagnosis? Like with
MRI
these,
brain.
yes, with these findings, with high suspicion of MS, but you did MRI and it was normal.
So what will be the differential?
Yes.
I
Do you
don't
know
know.
anything? Do you know a sister of MS? Have you ever?
Yes.
What is it?
You mean MRI brain only, but MRI spine will be abnormal, right?
Abnormal, yes.
Yes, yes.
What is it?
Myelitis optica, something like this.
Neuromyelitis optica, yes.
Yes.
Which is the diagnosis in this case? Because this patient has,
Okay.
yes, this patient has usually MS. They have in one eye the vision loss usually. Neuromyelitis, الصراحة it's a difficult diagnosis. But most likely neuromyelitis optica, they will have the vision loss in both eyes, and it's associated with intractable hiccups and vomiting, because it can cause affection of area postrema. This is one of the criteria يعني for neuromyelitis optica. Okay.
And it's considered subtype or a different diagnosis?
It's a different diagnosis, but it's a nightmare for neurologists because it's very similar to MS. Okay. So yeah, I think you did very well. You asked very good history. You used some jargon for the patient. You told abdomen aspiration. يعني بس be careful. Okay. You mentioned nerve conduction study and EMG. I think this might be against you because the patient is hypertonic. Everything is going with upper motor neuron. So I think better to avoid them يعني, because it's not a lower motor neuron lesion here, it's upper motor neuron, so don't mention them. Otherwise, I think you did well. You forgot to mention ophthalmology. The main complaint of the patient is the vision affection. Yes. Yes. But otherwise, you did very well, mashallah.
Thank you very much.
So I want just to discuss the NMO quickly. So as you said, a very important investigation in NMO is the anti-aquaporin 4 antibodies. But I think the diagnosis did not come to your mind. That's why you did not remember, maybe. Okay. And the management for the acute attacks like MS, we will use steroids. For the prevention, later on, we can use IL-6 inhibitors like satralizumab. And we can use eculizumab اللي هو complement 5 inhibitor. Yes, there are other medications, but these are the easier one.
Eculizumab and satralizumab, they're mostly used in NM. You are right.
Rituximab as well, also rituximab.
Because
I'm not sure about. Yeah, maybe rituximab, maybe because
rituximab, eculizumab,
CD2.
natalizumab. Yeah, the three of them.
Yeah.
Because
Eculizumab.
MS is always unilateral. MS is always unilateral.
Yes.
If it was bilateral and there was sensory level and the hiccup, can you tell me why the hiccup was there? What is the reason of hiccup?
The area involvement of area postrema will lead to hiccups. It's one of the criteria of
Postrema?
Postrema. Yes, this is the area in the brain. I don't know exact.
Brainstem. I think
Yes,
brainstem.
brainstem. Yes, involved in the nausea, vomiting center, hiccups. I think.
I
I'm not
think
sure
it's
of the
a
exact.
rare disease also, right?
It's a rare disease, but honestly speaking,
Yeah.
we had one case
Yes.
here
Yes.
in UAE, and we had this case honestly in one of our exams, the OSCE exams. And usually they
Mhm.
interchange the cases in between the exams.
Mm.
So for
So
OSCE,
the
they bring
only
to PACES,
difference,
and PACES they
mm.
bring to OSCE. Yeah.
So the only difference here, it will be the bilateral vision loss
Bilateral
Yes.
vision loss, yes. And the hiccups also is a hint.
and the
Also,
hiccups.
intractable vomiting is a hint.
And brain MRI will be normal, and spinal there will be sensory level.
Spine,
These are
yes, spinal, there will be involvement of 3 segments or more of the spinal cord.
and here
And
if
aquaporin 4 positive. Sorry?
if the examiner asks for differentials, then we can put the differentials, multiple sclerosis,
Yes.
then compression, trauma, headache,
Trauma.
trauma, hematoma, tuberculosis, tumor,
Parasagittal meningioma as well. Parasagittal
process
meningioma can be.
myelitis.
Yes.
Yes.
Yeah.
Most important thing is
And
MRI will be normal, and there will be sensory level.
most likely, yes.
Most likely.
Mm.
Oh, very nice case.
Yes,
Thank
very
you.
nice case.
Yes.
Well done, Doctor.
I
Thank
want to
you,
comment
doctor.
also, on Dr. Phoebe performance as first time participation with us. Perfect, really more than amazing. Although you didn't reach the diagnosis, but you have very good history taking
Thank you.
Yeah.
approach. Yeah, starting from the analysis, the relevant system. Although you didn't ask about the past medical history or you ask later, but it's negative anyway. But the other question you ask, all questions were target. And I guess the clinical communication you will get full mark with no doubt. Even you didn't reach the diagnosis will be in the differential, the clinical judgment, but the clinical communication is very nice. You cover the whole things related to the case. But I don't know if you ask about the pain in the eye because it's
No, I
also,
think she forgot the pain in the eye.
yeah,
Yes, you are
Yeah,
right.
yeah.
I think,
So it's
yeah,
very
yeah.
important for the optic
Mm,
neuritis. You have to ask about the pain, but you ask
mm,
about the eyes, both sides. Also add to them dryness. Of the phenomena you didn't ask, which is also missing, but still the history was okay. The hot bath, exposure to heat can make it triggered. You have to ask
mm.
these questions. I think here also it will be positive, right? Color vision, yes. Night vision, redness. All this will
Yeah.
make sense. Double
Mhm,
vision, doses,
mm.
timing, any particular timing to rule out Myasthenia gravis. But as first time, as I said,
I didn't
it's
ask for double
perfect.
vision and the night vision because there is loss of vision.
Yeah,
That's
you
why
can ask.
I afraid to.
You can ask before, I think, yeah.
Yeah,
Yeah, and
you can
even if
ask.
loss of vision, we can ask double vision, night vision, all this because it was in my mind and even in my preparation, but I didn't ask when it was loss of vision.
Okay, Dr. Phoebe, I will ask you a question. What vision might be affected in this patient or in this case? What specific vision affection? Tell me. In optic neuritis.
Um, I don't know.
The color vision, right?
Mm,
Optic neuritis, because this is the nerve for perception, color perceptions.
mm,
Particularly, you can offer the red color during examination.
mm, mm.
Yes, red vision. Okay. So
There's
it's
Okay.
one more
important
disease.
for us.
There is a color perception is lost. There's one more disease, gray color.
Yeah.
What is
Scotomas.
it?
Uh, this is
Optic
retinitis,
atrophy. I think recurrent optic neuritis can lead to optic
retinitis
atrophy.
pigmentosa. Retinitis
Retinitis,
Yeah.
pigmentosa, there is the night blindness and color loss also,
Yes,
especially
you're right.
gray color. Gray color.
Night and color. Yes, right. Night and color. Okay. The differential also here it's good as MS, NMO, NEMO or NMO, neuro myelitis optica. Yes, and I guess you can put optic neuritis as a stroke, but it will not be because there is also spinal lesion. It's difficult to mention it. You know, when Dr. Ryan mentioned the sensory level, I thought about anterior spinal cord infarction or MS could be, but there is multiple levels. So you have to think about multiple or multi-system affection, multiple sclerosis, and the NMO will be the one here.
I think
Driving.
neurosyphilis as well, or syphilis and neurosyphilis can cause both sensory level, transverse myelitis,
Perfect. Yeah.
and also,
But it's
but again, it's
primary
the
or
patient in
tertiary?
tertiary,
Tertiary, yeah. So it needs long
because
time.
there is neurological involvement. Yes.
Yeah, agree. Needs a long time, and you have to ask about the partner and so on, right? Any casual relationships.
Mm. Okay.
Any point to be
So
explained,
only
Dr.
the differential will be MS, and what else, Dr. Ryan?
Sorry.
NMO
If the case is
and MS. She said paracervical
You can
meningioma, but I
paracervical meningioma will cause the bilateral upper
yeah, spastic.
يعني في legs spastic paraparesis, but
Yeah.
it will not I don't think it will cause unless if it's causing high ICP pressure and causing vision loss, then I don't know.
I think some of the demyelinating disease you have to specify like this, but only NMO and MS.
MS.
Yeah, fitting the diagnosis or
you
meeting
can
the
put
criteria.
like a
Sensory
tumor or
level, you can
infection.
put
Yes.
You can put
sensory level,
infection,
you can
yes.
infections, trauma,
Tumor,
TB,
yeah.
tumor,
Infection, yes,
hematoma.
Mm.
Why you do not put TIA?
TIA as a cord lesion is difficult to mention because sensory level here can roll out any TIA.
Also,
That's why.
TIA will not last for
Not
1 week.
1 week.
Yes,
Yes.
yes.
Yes, it's 24 hours maximum. Yes.
Or stroke, or any stroke, it cannot even say that it's stroke.
Again, stroke will not explain the sensory level. You know, the sensory level here make it complicated. You have to think about something affecting the cord, not only the brain. But you can
Yes.
say occasionally a stroke with an anterior spinal cord, patient has showers. Okay, can be like this patient having, for example, AF and showering here and there, the brain and the spinal cord occasionally, but very difficult to present at the same time. Unlucky
Dr.
patient, I
So
mean, stroke with yeah, cord lesion. Okay.
so I just would like to ask a question. What was the first diagnosis? Because I do not get it. I was just a little bit.
Neuromyelitis optica.
Okay, that's okay. Pneumonitis. Okay.
Bas,
It affects which part of the brain? The medulla?
The same affection of MS, same way, same distribution, but the difference it will be bilateral eye affection as mentioned.
And
I
no
think
brain affection in
Mostly.
MRI also, Dr. Basim. And
in the
Yes.
MRI,
I
yes,
think
no
the
finding.
spinal cord, it will be more than 3 levels of spinal cord segment will be affected.
Yes.
Also, this is from the criteria. I remembered
Yes.
that now from my study for part 2.
Yes, it's one of them.
Yeah.
So MRI brain will be normal, but
Normal,
MRI
yes.
spine will be abnormal. Yes.
So
And also
can
the attacks are usually more severe and they last longer. MS usually يعني shorter time. So this patient now for 1 week. And the presence of aquaporin 4 antibodies and attacks of unexplained hiccups and vomiting they will have.
What about the ophthalmic phenomena? Is it same positive?
I'm not sure honestly, but I think why not? It's not specific for MS.
Okay.
I'm not sure honestly.
3 segment in spinal cord المفروض تكون sequence في each other صح؟ يعني مش في different
أيوة.
part.
لا each other.
Dr. Ryan, as you told that this is a spastic lesion, we will not go for the nerve conductions and EMG.
Yeah,
Yes.
she mentioned yes.
And
Yes.
it is likewise, we 2 days before we did the case of subacute combined spinal cord. This is we were doing nerve conduction and EMG.
I was not there in that case, but we should not mention both in the same case. So if the finding suggestive of peripheral neuropathy, we should not mention MRI, brain, and, because we had one this mock PACES exam when the British people came to assess our center. So there was one of the cases, a stroke in young patient, and we mentioned in the stroke patient, he had hypertonia, all the upper motor neuron findings. We mentioned nerve conduction study and EMG, and they commented on that. They said we should not do that.
I think in
It makes sense, honestly.
in subacute combined degeneration, there are both regions, upper and lower motor neuron region. That's why we
So
are doing nerve conduction, I think.
yeah, so if there is both affection, then that is
Yes, you're
normal.
right.
But that
They want
patient
to
was
limit, yeah, they want to limit the test for unnecessary testing, particularly.
yes,
So
yes,
it is only for the upper motor neuron regions. We will not go for the nerve conduction and EMG.
Exactly.
yes.
Okay,
Don't
thank you.
just mention everything and anything. You have to make sense for the investigation before saying it.
Yes.
You said, doctors, that the cause of vomiting and hiccup, it was because of affection of which site exactly?
Area postrema. It's not necessary, honestly, to know all these details, but if asked, it's affection. You can tell the patient this is part of the disease. It can cause this problem because of affection of part of your brain. So it's called the area postrema syndrome.
It is in
They will
which
have
part exactly
hiccups.
of the brain? It
I
is in
think
which
the
part
middle.
in the brain? Okay. The medulla. Okay, thank you.
I think so. I'm not quite sure. Let me check it and send it in the group.
Okay,
Yeah,
thank you so much.
perfect.
It's a very nice case.
Welcome. Welcome.
Yes, and both cases really are nice. And Dr. Phoebe, as first performance, she did well. And even the question, the examination, she did most of the things. Any question or comments before ending the session? They were nice. Any question? Any comment? Okay, seems satisfied. Thank you, Dr. Ryan and Dr. Phoebe.
Thank you, Dr. Basim, for making me to
Yeah,
practice today.
you are most welcome.
Thank you,
most
Dr.
welcome.
Basim and all. Thank you, Dr. Phoebe.
Thank you.
Thank you, Dr. Ryan. Thank you very much.
Thank you, everyone, and the attendants and the participant, all of you. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.